Okay, good afternoon, everyone. We're going to start our session. I am Ermelinda Pedrosa, endocrinologist. I come from Brasília, Brazil. I have the honor to be Vice President of the IDF, and I'm going to chair this session, which is about the stream of technology and artificial intelligence, and we have this topic on healthcare provider bias in supplying technology to diabetes management. We have two very important speakers today here. Professor Alice Cheng, that she is very well known from everybody, but she lives in Toronto, in Canada, and has a very enormous contribution to the field of diabetes, and she's going to give her opinion about this fact. And then we have Dr. Paolo Bartolo from Italy. He is also an endocrinologist, and the main focus is with equity with people with diabetes. He's going to refer to his own experience as a person living with type 1 diabetes. So it's a very big pleasure to have you both here. So the floor is yours, Professor Alice Cheng.
Okay, wonderful. So thank you very much, Madam Chair, for the kind introduction, and thank you to all of you for sticking around for the afternoon of day 2 of IDF. So my job is to spend the next 15 minutes or so speaking to you about healthcare provider bias, the clinician's perspective when it comes to technology. And here are my disclosures. So by the end of this, I'm hoping you'll have an understanding of how provider implicit bias can influence our recommendations, to have a reconsideration as to which patients we consider quote unquote ideal when it comes to diabetes technology. And I'm going to share, I think, a practical strategy as to how we can address some of that implicit bias that all of us have. And just to set the stage, I mean, we're here standing in 2025, and we're talking about diabetes technology, specifically glucose monitoring technology, but also continuous subcutaneous insulin pump or CSII technology. And I would say also specifically automated insulin delivery is really where I'm going to focus a lot of my attention around the biases that we all have, I would say, as healthcare providers, and ways that we can try to address that. Because we know from a recommendation perspective, insulin pumps, automated insulin delivery are recommended in those living with type 1 diabetes as the preferred choice. And this is true in US guidelines, it's true now in Canadian guidelines, it's true in other guidelines from around the world. However, the reality is it's not necessarily being implemented in that way, and the question is, why is that? So how are we doing? How are we doing in terms of implementing technology for those living with diabetes? Now, looking in the type 1 diabetes space, this is T1D Exchange. These are data from the United States. And arguably from 2016 to 2022, there has been a nice increase in the use of CGM, continuous glucose monitoring, in the use of insulin pumps, and in the use of AID, automated insulin delivery. And that may or may not account for the improvement in A1C over time, but I suspect it is a significant contributor to the improvement in A1C that we also see here on this graph. But in terms of implementation in the majority of people living with diabetes, these are Canadian data, and Canada would be considered a country with universal health care, a country that would be in the high income bracket when looking at income. But looking at Canadian data, we're sitting at about 40% of individuals living with type 1 diabetes on insulin pump, and these are data out to 2018. And then if we extend it out a little bit further with a larger cohort of individuals, we're sitting at 42%. So this is by no means, I wouldn't even expect 100%, but even anything above 50 would be nice to see, and we're still sitting at 42%. So why is it, right? What are the reasons why there is still this barrier to having more people accessing diabetes technology? Now, the first thing that everybody thinks of is money. It's too expensive. We can't afford it. That's why we're sitting at 42%. But I don't know that that's the whole story. So this was a very interesting study, looked at about 1,500 adults living with type 1 diabetes from 5 Canadian provinces, and they looked at the electronic medical record. What I'm showing you here is the percentage of people living with type 1 on a pump in a no pump funding program, meaning a province where there's no reimbursement for insulin pump. 37.7%. So for yourself, I want you to guess in your mind what the number would be for those provinces where there is pump funding, i.e. the province will pay for the pump. So now that you have that number in your mind, let me show you what the actual number is. 48%. Higher, yes. Good? No. So money is not the sole explanation. Then you could look at the income brackets of the individuals, because even though there's pump funding, there may be some out-of-pocket cost, and maybe that's the contributor. So again, in provinces where there's no pump funding, clearly the higher the income, the more likely you would be on an insulin pump. But even in those provinces where there is pump funding, the biggest impact seems to be on the lowest income tertile, in that they are more likely to be on a pump, but it's still a low number. And then there's still this gradation. So clearly money is not the sole explanation for why we're still sitting at 42%. Another potential reason is us, healthcare providers, having these, I think, antiquated, old, traditional ways of thinking, saving technology for the good patient. So the good patient, one of which could be defined as younger. So is that true? I'm going to show you some real-world data looking at devices with automation and showing you that clearly age is not a predictor as to who is going to do better or worse. And arguably, maybe age is actually a predictor of who might do better, actually. So these are data from the Minimed 780G system, 100,000 users. And in the purples, looking at the overall cohort, the blue is looking at those under the age of 15. And here you have the glucose management index, the time in range, time below range, and then the combination. And then here now I'm going to add what they define as older. I'm not responsible for it, age 56 or older, as being actually better in terms of achievement of these glycemic targets. And then what about a different system? So this is the Omnipod 5 system, another automated insulin delivery system, looking at 69,000 users. And what you can appreciate here, age is across the top, and then you have the different parameters in rows. And if you look at the over 65 and the over 70 age group, fair number of individuals represented, time in ranges of 73.5%. And actually better than the younger age groups. So age should not be a barrier by any stretch of the imagination. So what about we should save it for people who are engaged in their diabetes? And that would be reflected with a lower baseline A1C. Well, here are some data looking at the fact that lower baseline A1C are probably the people who will gain the least. So this is a small study, retrospective analysis, 230 youths and adults living with type 1 from a single center, individuals already on insulin pump therapy transitioning to automated insulin delivery. And this is looking at what happened over time, stratified by baseline time in range on the left, or stratified by baseline A1C on the right. And what you can appreciate on the left is that the group that had TIRs under 50% had the most gain in their time in range, compared to the group who was already above 70% to begin with. They also improved when switching to automated insulin delivery, but a much smaller magnitude of benefit. And similarly on the right, looking at A1C, those in the circle with the highest baseline A1C had the greatest improvement in their A1C, compared to those who already had an A1C that was close to target. So if anything, the group with the higher A1Cs are the ones who are going to benefit the most. And this is another study. This is looking at a New York City health and hospital system, looking at those who had higher A1Cs at baseline. And what was found that when they switched over to automated insulin delivery, average A1C reduction of about 1, and reduction in diabetes-related hospitalizations as well. So if anything, those with higher A1Cs would probably benefit the most from being on diabetes technology. And this is another common barrier, is I'm going to save this technology for people who know how to carb count, because you need to carb count and carb count well for this technology to work. I think that's an old thought. When I was training, that was certainly how I was taught, and I think we now need to somehow unlearn that. Because carb counting is exceedingly difficult, and with our current technologies, I don't think that needs to be a barrier. So this, I thought, was a brilliant study. Simple study, 34 individuals, adolescents living with type 1 diabetes who were scheduled to start the 780G system, randomized to either a fixed group, meaning they had a simplified meal announcement. or flex group. Flex group is the precise carb counting that we teach people and make them try to do. The way they did it was that for the flex group, it was precise carb counting as we have traditionally been teaching people. And on the right-hand side, the fixed group had their total daily carbs over the last few days, so they get a sense of your average total daily carbs, shave some off the top, so just take 60% of that, and then divide that by 3, and that will be your number of carbs for your meal. And then if you're gonna have a larger meal, you multiply that by 1.5. If you have a smaller meal, you take half of that number. So functionally, it ended up being 20, 40, 60. So everybody put in about 20 grams if they're having a small meal, 40 grams if they're putting a usual meal, and 60 grams if they were having a bigger meal. That was it. So what did they find? So this is now looking out to 12 weeks, okay? So this is the short part of the study. So the first part on your left-hand side is the run-in period, and then you have the sensor-augmented pump period. This is just to make sure that the pump is working, they know how to use it, and sort of get started. I'm showing you here the flex data. So these are the individuals with precise carb counting. Time and ranges, the green sections went up, definitely went up upon initiation of automated insulin delivery. But how do you think the fixed group did, where all they had to do was 20, 40, 60? They did pretty well, right? They didn't do as well as the precise group, but my goodness, they did pretty well. There was a clear improvement in the time and ranges, even though it was a 20, 40, 60. So what was different between them? So if we look here at meals per day, so the number of times they announced a meal to the system. Now, it was asked of the fixed group to still announce every meal, but you can see that that did not happen. The fixed group, 3.9 meals a day. The flex group, 5 meals a day. So the flex group really put everything in, including snacks. The fixed group probably just put in their meals. So what was different was the amount of autocorrection. There was significantly more autocorrection in the fixed group. Now, some people would say that's cheating. I would say that makes no sense. Of course that's not cheating. I don't care where the insulin comes from. The fact is the insulin is there, and if the machine does it or the person does it, why is that different? So I think we really need to remove that fix that we have of needing to have someone carb count quote unquote well. Now you could say, well, those data are only out to 12 weeks. What about longer data? Here are the data out to 12 months, and you can appreciate that the fixed group, the group that just put 20, 40, 60, still did really well. And obviously this desire to get rid of carb counting is a strong one. There are many studies now looking at ways to reduce the need for carb counting, all because carb counting is difficult, and I think it's time we start removing that as a barrier to accessing technology. Another barrier is the type of diabetes. We believe that this should be given to those living with type 1 diabetes. Well, I think that's also going to need to change in that there are emerging data showing success of automated insulin delivery in those living with type 2 diabetes. And this is recently published, JAMA Network, showing significant improvements in time and range in those living with type 2 diabetes. Then there's the question of, are there other biases? And sadly, the answer is yes, but it's not sadly. This is the human condition. All of us have implicit biases. So implicit bias is where we have an unconscious favoritism or prejudice against a particular group, but it's unconscious. And there are certainly data to show that. This is from a single center in the United States, looking at those who were Black, those who were non-Black, and looking at the likelihood of having a CGM conversation, a CGM initiation, a pump conversation, or a pump initiation. And by being Black is associated with a lower incidence of these things. And this is more recent data from the UK, where they interviewed 29 healthcare providers recently, last year. 29 healthcare providers from centers across England, and asked them about themes around why is it that those with lower socioeconomic status are often less likely to use technology. And these were some of the themes that came out: deprivation and socioeconomic factors, social, ethnic, cultural, staffing and service capacity, which is more of a structure thing, unconscious bias, and the postcode lottery is a very UK phenomenon. But these are some of the quotes that I thought were very telling. So this quote essentially says that when a family walks in, we are instantly making judgments, and that's because we're human beings. That's not going to stop. We're making judgments based on how they're dressed, how they're speaking, and then making decisions unconsciously in our minds as to whether this is an appropriate candidate or not. And we'd be lying to ourselves to think that we're not doing that. And then we make excuses for ourselves as to why we did not offer technology to a particular family or person is because, oh, for safety reasons, we should not give it to them because I don't think they can handle it. And then there's also recognition that we also have positive biases, that someone who looks and talks like us, we're going to favoritism them and therefore maybe offer them stuff we don't someone else. So this is real and we're all guilty of it, but we shouldn't feel bad about it. We just need to know what we can do about it. And it's critical that we keep this in check because number one reason why people are not on technology is because their healthcare team did not suggest it, which makes a lot of sense because I've been seeing you for 10 years. You know me well. If you don't suggest it to me, there must be a good reason you didn't suggest it to me, when in fact it may not have been a good reason at all. So we need to keep ourselves in check. And I think the way we can do that is just make it systematic that at every visit we have a technology conversation with everyone. Not everyone's going to say yes, but then we've done our job, which is to offer it to everyone, and then the decisions can then be made by the individual. Because what we need to do is stop putting up hurdles that people have to jump through in order to access technology. And we need to start considering this kind of model, which I'll show you on the next slide, which I've taken from another speaker, but I think is brilliant. It's time to turn upside down the model that I was trained with, which is that there's a small percentage of people that are ideal and a large percentage that's not, and flip that on its head so that the vast majority of people are ideal with a small percentage that's not. So thank you very much for your attention.
Okay, I think you can, the floor is yours, Paolo. Very good. If there is no president, I just make some of the
Good afternoon, everybody. My name is Paolo. It's Paolo Di Bartolo, and I'm an Italian diabetologist. I'm also a person with type 1 diabetes. I'm here in Bangkok with my wife, Joanna. Ciao. And first of all, I would like to thank the scientific committee for inviting me to be part of this session. The task I received is to present you in 50 minutes, and this is a very, very hard task. The bias I perceived, and I have experienced firsthand as a person with type 1 diabetes, but also as a diabetologist in adopting and prescribing diabetes technology in people with diabetes. These are my disclosure, but I believe that the most relevant disclosure is this. Obviously, this will be not only an evidence-based presentation, but it will be a presentation based on my personal life experience as a person with diabetes and as a physician, a diabetology. And so any reference to real events and or real person is not purely coincidental. So diabetes technology has advanced in the last decades, and diabetes outcome improve with this new technology. However, today, barrier still remains, still an obstacle, the adoption of diabetes technology in people with diabetes. What I would like to do in the next 15 minutes is to convince you that now we have several opportunities to overcome this bias, to overcome these barriers. Even with the improvement in this field, we are missing the opportunity to help more people with diabetes. 1 on 3 of all people with diabetes succumb for the diabetes complication. This data comes from a type 1 index. And I really believe that you are in agreement with me. It's imperative for us to do everything we can do to prevent this from happening. Glycemic control remains paramount to prevent cardiovascular mortality. This data present the cumulative incidence of cardiovascular complication from the FIN-DIAN 50 years of diabetes study, comparing people with type 1 diabetes with people without diabetes. These data clearly show that we need to change the way we manage diabetes now. But talking about cardiovascular diabetes complication, we have also some good news. This data comes from the Sweden Diabetes Register, a large population, more than 80,000 people with type 1 diabetes, comparing a large group of pump users, more than 2,400, with a very, very large group of people with type 1 diabetes treated with MDI. And in this study, insulin pump use was associated with a decrease in the risk for fatal or non-fatal coronary heart disease by 45%, for fatal cardiovascular disease by 42%, and for total mortality by 27%. And here we were in 2015. We were in 2015 when this study showed us that there was an opportunity to help people with diabetes, type 1 diabetes, to change their story. But where we are now? This data comes from an Italian initiative, an initiative of the Italian Association of Clinical Diabetologists. A very large type 1 diabetes register, more than 42,000 people. And from 2018 to 2023, the proportion of people introduced in the use of pump use or in an automatic insulin delivery system increased by 57%. But even with an increase by 57%, only the 35.9% of our patients get the target for a good glycemic control. So something needed to change. We know that the need is there, and we know how a better and a broader use of technology could help. But the question now is, what standing in this way? I believe that the answer is there. We are faced a condition that the diabetologist, the endocrinology will know. The condition named clinical inertia. Here is a description of clinical inertia. But now we are faced a new form of clinical inertia, a diabetes technologies clinical inertia. Diabetes technology clinical inertia is a multifactorial situation, condition, and it is related to factor related to clinician, factor related to patient, and factor related to the health system, to the institution. Clinical inertia is the enemy of the therapeutic success. As clinician, you already have shown this data, we need to be aware of our bias in prescribing diabetes technology. Our bias is one key to a more equitable diabetes technology use. This data comes from US, and please take a look. 34% of providers demonstrate implicit bias based on patient race and ethnicity. Moreover, as clinicians, we cannot ignore that now we have a huge number of global guidelines. Here is the ADA, the last ADA standard of care about diabetes technology in people with type 1 diabetes, and the 2023 ATD consensus about the use of an automatic insulin delivery. All of these guidelines make a proactive recommendation for use of diabetic technology in the management of type 1 diabetes. And here is the new Italian initiative, the new Italian guideline that point to diabetes technology as first-line therapy. These guidelines were developed with a very rigorous method, the GRADE method, and the scientific society and the National Institute of Health joined together for the development of this guideline. Please note, in people with or without type 1, uncontrolled type 1 diabetes, recommend to offer the patient the option of an insulin pump therapy rather than an MDI approach. In people with type 1, is recommended to offer the patient a real-time continuous glucose monitoring system rather than self-monitoring blood glucose. And finally, all people with type 1 diabetes should be introduced to the use of an ID system. Please note the strength of the recommendation, strong. So now a question arises. As clinicians, are we aware of the degree of responsibility we have in determining and maintaining clinical inertia? I believe that the answer is not. This is a web survey among 153 Italian diabetologists and about clinical inertia, and where the Italian diabetologists were asked, who do you believe is the most accountable for clinical inertia among clinician, patient, and healthcare system? Here is the answer. The diabetology were willing to accept a degree of responsibility for clinical inertia, but tend to avoid accountability by placing emphasis on the negative outcome associated with patient and at a lower level, at a lower degree, health system. But please, take a look at what patients say. You already have shown this data. This is a JDRF UK market research to understand the motivation and barrier to use of pump therapy. Please note that the most relevant barrier is my clinician has not recommended it to me. Don't know how it will be benefit to me. Don't think it will improve my blood glucose. So the 52% of the barrier reported by patient can be solved with a healthcare provider, a patient communication. But please note also that for 27% of people do not want to use an insertion device and don't like the tubing. So we have also emotional barriers for the use, for the adoption of diabetes technology. And this was also my story. I moved in 2018 from MDI to CSII, to an insulin pump therapy, after 40 years living with diabetes, after more than 40,000 insulin injections during my lifetime. And I move only when a system like this become available in my country. When an insulin pump without any tube or catheter finally arrived, although I was the first in my country to promote the establishment of an Italian study group about diabetes, and I thought I was the first coordinator of this study group. So I believe that this story of mine learns us that even we have some patients that are well informed of the benefit of diabetes technology. For this patient, emotional barrier can be very, very, very hard to be overcome. And maybe we can ask an help to the new and the last diabetes technology, because with the new technology, maybe the most of the emotional barrier of our patient can be overcome. My presentation is nearing to hand. I told you something about health system related barrier for the implementation of diabetes technology. And here is a beautiful example of how the health system barrier can be overcome. These are a technology appraisal guidance on hybrid closed-loop system released in 2023. And this happened when all the stakeholders come together and understand value of technology. Please note that following the recommendation of NICE, NICE is a very, very rigorous institution. Following this recommendation, an estimated number of 150,000 people with type 1 diabetes will receive an AID technology under the next year and in the next 5 years. And this become available, they become possible only when clinician, patient advocacy group, industry, and institution come together, come in a common voice to emphasize, to underline the value of technology for people with type 1 diabetes. So, here are my conclusions. Together we can overcome diabetes technology clinical inertia. We can overcome together diabetes technology clinical inertia with diabetes technology with a person-centered approach where diabetes technology come first in therapeutic pathway, where our patient is not just the one who receive our prescription, but is an active part of a project, is an active part of a multidisciplinary team, is not only the one who receive education, but he is an educator. He is a part of a structured diabetes technology education program. He is a part of a common table with the scientific society, with the institution, with the industry to bring together a common voice. And finally, is actively involved in the development, in help us to identify diabetes technology, clinical inertia, and clear metrics indicator to track clinical remission and to improve upon. So, this is a gardenia flower. Someone told me that in Thailand, for people who live in Thailand, gardenia flower is a wish for an happy beginning and a hope to go forward. In our case, go together. Really thanks for your attention.
Thank you very much, Dr. Paolo. Now we still have about 10 minutes, so we can make questions. Please feel free.
把笔弄出来。
嗯？
现在帮我需要用到笔的时候，
什么笔？
手写笔。
哦。哇。
你的平板有剪映对不对？
对。嗯？对，平板有。
拿个平板来做。
这是手机耶。我之前删掉。
And you can use the microphone. Oh, perhaps I should start just to motivate the audience. So, Professor Sheng, I know that Canada has one of the most structured healthcare system in the world, and I wonder how you motivate patients, people living with
当你们出国的时候是买外国插头。
technology. Is there a protocol that you follow? Because we know that it has been very much of debate among people living with diabetes. But anyway, of course, the health system has to carry on because we have to consider cost and everything. So how is the experience in Canada in terms of putting people, of offering people to get access to this technology?
没有，我们家里箱子里面找到了。
The simple answer is structured conversation. So the person living with diabetes will certainly see the healthcare professional, primary care, specialty care, diabetes team, and the idea is that everybody broaches the subject and has that conversation with the individual. Even though access is there, as I showed you the data, I mean, it's not 100%, nor will it ever be, because of, as you very beautifully illustrated, there are a lot of personal reasons why people are not ready for technology at that time. But I guess my job is to not give up, right? So they say no, okay, great. No is a great answer. And then every time I see you, I'll bring it up. It's gotten to the point where the person walks in the door, and if they don't want to talk about it, they'll just say, Dr. Sheng, I know you're going to ask about it. I'm not ready. I say, great. Then we talk about something else, right? So I'm not judging, but I'm also not stopping. So I think that's my job. And then the rest of it is entirely the individual's decision because they're the one living with it, and therefore it's their choice.
But just carry on this, then I will ask you to do some. To give the experience in Italy. So let's say the person has received the proper technology. So how do you follow up based on the protocol? Do you establish, I presume so, a target to be achieved, and if the person does not achieve, what do you do? I mean, what will be the routine follow-up?
So the access to the technology is not dependent on achievement of goals, because that would really be fair. There's a variety of reasons that happens. Follow-up would be very similar to usual. Follow-up with the endocrinology, follow-up with the diabetes team, regular checking of the glucose parameters, and seeing what the barriers are in terms of achieving target. But the key is that the access to it, though, is not predicated on results. It's very much the personal decision. So each province is a little different. In Ontario, every 5 years, they can get a new pump. They can then choose a different system if they choose to. Access to the CGM is not covered by government. So the CGM part still needs to be out-of-pocket cost or private payer. So it's not a perfect system by any means. However, I think my job is to make sure I don't stand in the way. I think that's the biggest message.
Okay, thank you. For you, Dr. Bartolo, you showed that there has been this recommendation in Italy that all the patients, all the people living with diabetes should be offered the technology. Even if they are not all controlled. You also showed the data from the UK in 2020, so let's say 4 years before that, 27% of the patients did not accept the technology. How is the situation in your country after you have this very robust recommendation of offering if the patient is not is controlled or not? What was the reaction? Accept or not?
As I told you before, the situation is very different patient by patient. We have not a precise data. We have this fantastic initiative. The name is IMD Annals Initiative, a very, very large type 1 diabetes register. And until now, we have only data about the proportion of patients introduced in insulin pump therapy and in an IID system. Unfortunately, we do not have at this moment data information about the proportion of patients introduced in a real-time continuous glucose monitoring system in patient and the proportion of patients who accept and who refuse to be introduced in with this approach. However, I repeat, now we have fantastic new technology. I believe that a very, very large of our patients will be find a solution for their need with the new approach. We have to individualize the approach. We cannot just offer an insulin pump. We have to show every kind of insulin pump is now available on the market, every kind of real-time continuous glucose monitoring system we have now available at least in Italy, and then we have to ask our patient to make a choice and to decide what could be the best solution for the patient.
Yeah, thank you. So I think we have a question. Could you please tell your name and where you come from?
Thank you. My name's Raymond. I'm a GP and a specialist in diabetes. I work in the UK. Thank you for your informative talk. Just one question from me, if I may. Technology and diabetes, there's a big inequality in the UK with regards to who uses or who takes up this technology, especially amongst the working class and the ethnic minorities in the UK. Can I ask, how best do you think we could reduce or, narrow this gap? Because rather than improving the lots in this group, diabetes technology is actually even taking them more apart and more disadvantaged. Thank you.
So maybe I'll start with some ideas. So I think at a base, there needs to be access. And I think the UK is a wonderful example of the NHS now allowing access for AID for those living with type 1. So that's the foundation. Next, we need to educate healthcare providers to understand the implicit biases that all of us hold. Not to change them, because like I said, we can't change them. That's the human condition. But to find a systematic way of ensuring that the conversation happens with everyone. But that also needs to be practical, because if there's a language barrier, it's very difficult for me to explain AID to somebody in whom we're speaking a different language. So I think from a systems perspective, we need a way to be able to do that. And then the third piece I say is from a community and culturally, for there to be more conversations about technology, because sometimes the barrier is that it's not accepted. There's even more stigmatizing, because now it's very outside your diabetes and visible to the world. So I think addressing diabetes stigma is going to be the other piece of the puzzle.
Yeah, in Italy, as I show you, we have a national, very, very strong clinical recommendation for the use for the prescription of diabetes technology in people with type 1 diabetes. We have one national rule, a law that well describe, well indicate that we have to prescribe this technology to people with type 1 diabetes. Unfortunately, in Italy we have 21 regions, different regions, and these regions are free to accept or not to accept the Italian recommendation, the Italian law, the Italian rule. So we find a solution to overcome this iniquity, because in some area of our country, patients are not allowed to receive the prescription for an insulin pump, a new insulin pump system, a patch pump or a example. We involve the patient advocacy group. We involve the patient association. We ask to the patient to the patient association to be part, to be present at the table with the institution. We ask to the patient association to push pressure on health system institution, to push pressure on health region system, allowing all the people to type 1 diabetes to receive the most appropriate therapeutic approach.
So our time is over, but I think we can get just 5 minutes more. So I think they came first, yeah.
Kia ora, I'm Jo McClintock, a psychologist from New Zealand. So we now have full funding for insulin pumps and CGM for people with type 1. I'm wondering how non-prescribers, because everything has to be on prescription, how do we convince our prescribers that those with mental health issues, eating disorders, all of that kind of presentation would benefit from technology, because we're running with a real risk profile of clinicians or the prescribers rather than our patients who want these devices but are told no.
That's a fabulous question. In fact, there was a session yesterday looking at automated insulin delivery in the vulnerable populations, quote unquote. I can tell you my own experience, right? So when I trained, I was told who should get technology, and it was not the group that I just referred to. And the group you just described would have not been on that list. So over the course of my career, who have I learned the most from? And this is exactly what Paolo had mentioned, is the people living with diabetes. So I think it's actually hearing the voices of people living with diabetes and actually them saying that they want it. And then I think for us to be more open-minded and then hearing from colleagues about someone who's tried it. Because it probably, I would like to think, comes from a good place in that there's fear of safety and something bad might happen, they might get DKA, etc. So it's coming from fear. But then I think when they see the reduced burden, that will be helpful. Now, the other answer is we'll do the studies. The problem with do the studies in the population you just described is that's probably not realistic. So that's where anecdotes would actually be really powerful. So if it has been tried in somebody by a colleague somewhere and they share that story, I think that will go a long way. So I think in that population, it's not going to be data, it's going to be stories.
Final question, please. Oh.
The microphone is off.
We'll repeat it.
Maybe the microphone is off.
Okay, that's okay. So
Oh, yeah.
Okay, it's okay now.
It's actually a follow-up on the previous question. I also have a question out of fear, because I fear that when, for example, in Aruba, I'm from Aruba, patients or individuals with type 2 diabetes want to have a CGM or technology, but they're said, no, we cannot for this and that reason. Which strategies can you advise to diffuse actually feelings of being excluded or being discriminated of the patient? I ask these questions out of fear of the person feeling not very much in trust with the physician or the caregiver. So I really want to know if there's any advice on that.
Interesting. So you're asking about the other side. So someone asking for technology, being told no by their provider, and then the impact on that individual.
The impact on the individual.
Right. So I guess the question is, why was the answer no? So one of the answers may be because there's no access, it's not reimbursed, et cetera, et cetera. And then if that's the case, I think explaining it, but then that's also going to worsen their feelings of exclusion. And then I guess avenue for advocacy would be the conversation to have. That's a great question. I don't know how, I mean, it'd be explaining the rationale for the no. And sometimes there is no good rationale for the no. That no is coming from a place of bias. And that's going to require reflection on the person who said no, which is really hard to force that to happen. And I think, again, the voices of people living with diabetes need to be as loud as possible. Not every healthcare provider will listen, but without the voice, there's no chance of listening. So it's almost that the people living with diabetes speaking up as much as possible.
In Italy, we are not allowed to prescribe diabetes technology, advanced diabetes technologies to people with type 2 diabetes. We are allowed to prescribe only the flash system, continuous glucose monitoring system, the system flash, and in people with type 2 diabetes treated with insulin. No more.
Yeah, and also I would say that I think the people living with type 1 diabetes have more power in terms of achieve advocacy. And the type 2 people, unfortunately, they are sort of lost. So everybody thinks of the burden of this technology, but we have to realize that the burden of the complication, considering that they are majority, will even cause more burden to the system. So it's a big issue.
There is we have a low level of evidence of the benefit of diabetes technologies in people with type 2 diabetes, and we have to make a choice. If we want to invest where there is evidence, people with type 1 diabetes, because we have not enough money.
Yeah.
We have to decide. If you have evidence, if we will have evidence, we will be allowed to prescribe.
Having said that, though, I do want to say one thing. I've learned to still offer it in type 2. They will have to pay out of pocket, and not everyone can do that, right? But if I don't even offer it, then I'm actually doing them a disservice. And I've heard myself in the past, someone living with type 2 asked, I want to go on a pump. And I said, oh, no, that's for type 1. Like, I've said that. And I feel bad that I said that. And I now try to not say that. I will tell them it's not covered. You'd have to find a way to pay for it. But then it's not my job to say, no, you shouldn't get it, right? So, but it's been a learning curve for me.
And this is a very good debate, but I really have to finish. But I just would like to add that we have to, it's not only a number, type 1 or type 2, because the type 2, there is a very wide scenario of each phase. For example, if the person is a very old lady or a gentleman with so many comorbidities, fully use of insulin, so then it would be acting like a type 1. So we have to consider all these situations in the clinical scenarios and conditions. It's not only, okay, type 2, no right or no chance of getting these things, but it's a very good debate, you know. I'm sorry, but I have to close this session because
really, thanks.
Thank you very much for the attention. Thank you very much for you too for brilliant expositions and discussion. Thank you very much.